Prescribers have been putting their trust in Prescriber's letter for years, and now there is one more reason to do so. You can now hear the PL experts tell you about important new developments in drug therapy. That's right, you can now get the truth about drugs, plus access on your iPhone, iPad, Android, or other device where you can listen to the experts whenever you have a moment. Special invitations to webinars where you get tips on drug therapy that save you time and solve problems. Convenient options to get AAPA approved CME credit automatically for doing things you do anyway. Prescriber's letter is totally independent and has no connection with any pharmaceutical firm. Prescriber's letter never accepts any advertising. Everything published in Prescriber's letter is completely objective.
I can't tell you how many times, after reading an issue of PL, that I use that information for my patients and/or advise my colleagues. You guys make me look smarter than I really am. Keep up the good work.
Wow, I have to tell you how impressed I am. You're succinct, timely, spot on, and so unbiased as to be a breath of fresh air. And you were not shy about your hard-hitting truths. I am not throwing these out.
Prescriber's letter lets you answer the latest drug questions with confidence, avoid medication errors, give your patients the most current treatment regimen, and the best part is, that is just the tip of the iceberg. You get even more out of your subscription online. Each concise recommendation has more information available to help answer your questions. Get instant access to these detailed documents online. Each PL detailed document gives you in-depth answers to your questions. For example, in-depth analysis of relevant studies, relevant treatment guidelines, PL patient education handouts in English and Spanish, relevant black box warnings and med guides, PL drug comparison charts, and so much more.
Prescriber's letter is an excellent way to keep up. With the subscriber section of the website, I can read in depth about the topics in the letter. All the work of sifting through mounds of monthly information is summarized by experts. I am impressed and delighted by the content, organization, helpful tables, and other still to be discovered aspects of prescribersletter.com. It is obvious that many talented, bright, and obsessive-compulsive people have labored long and hard to create this treasure trove of useful information.
And now, we are adding PL voices to the PL detail documents. When you search prescribersletter.com, you will now see PL voices in the search results. You can eavesdrop online or on any mobile device. Here's a short segment from a recent session.
Hello, everyone. This is Sherry Boehringer. I'm an associate editor for Prescriber's Letter and Pharmacist's Letter. And let's go ahead and move on to our next topic, and that is about insomnia. And I'll tell you, this has actually gotten quite a bit of press lately. And what has happened is there's a study that's recently come out that suggests that there's a relationship or an association between insomnia medications or sleeping pills and an increased risk of mortality. I did want to go ahead and turn to Dr. Dan Kripke, who is actually the lead author of this new study that we're talking about. And Dan, you know, there still seems to be some mystery about why insomnia medications, especially when taken just a few pills per year, might actually increase the risk of mortality. So I'm wondering, can you help us to explain that?
It's not a mystery, Sherry. We know that they interfere with breathing at night and maybe making apneas occur at night that people don't wake up from. In addition, we know they cause accidents, we know they cause falls, they cause confusional spells at night, and those symptoms are things that occur with the first pill. They probably occur more with the early doses than later after there's behavioral and pharmacologic tolerance. And we also know the medicines cause infection, they cause cancer.
It seems to me that these patients who get these medicines might be at increased risk, and maybe the author could just clarify how he separated the risk of the medication just from the populations being different.
Yeah, that's a good question, and Dan, maybe you can help answer that. Also, I also wanted to mention that we have another sleep specialist with us today, Dr. Charles Samuels. So, Dr. Samuels, if you wanted to jump in and help answer these questions too. But Dr. Kripke, to me, I looked at it too, and to me they looked like they were sicker patients, the ones that were receiving these sleep medications. So can you comment on that?
They were a little bit sicker, but not 4 times sicker to explain a 4-fold hazard ratio for death. And in our statistical control, we stratify on level of health. So our hazard ratio is based on comparing patients with exactly the same chronic illnesses, taking sleeping pills and not prescribed sleeping pills.
Okay.
So we've controlled for that to a great extent. It's true that the control isn't perfect, but it's pretty good.
Yeah.
Okay.
This is Steve Nissen. I really have to weigh in here and
Steve.
say that, first of all, nobody hates these drugs more than I do, and I don't prescribe them virtually ever. Having said that, the study is really confounded by indication, and we've seen this over and over again, that people who get a drug, in this case sleeping pills, are different from people who don't get the drug, and no amount of adjustment can compensate for that. So that what we really need is a large RCT to answer the question. Having said that, I don't see the benefits of giving the drugs, which is why I don't use them. They're addictive. Once you get people on them, it's hard to get them off. And frankly, a lot of physicians use them to get patients out of their hair, and that's not very good medicine.
That's true.
If I could just weigh in here, Sherry?
Yes.
It's Dr. Samuels.
Yes, thank you.
So this is a very, very controversial topic. However, number one, this is a brilliant paper from an epidemiological perspective from an author who's been doing this for many years, and we would all consider quite, fundamental in the field of sleep medicine, Dr. Kripke. So the paper uses good methodology based on data extracted from electronic medical records, large numbers, and gives us, from Hill's criteria of causation, probably the strongest piece of evidence of association, not necessarily causation, and that's a dose response. So that's really helpful. But it's helpful to administrators and policymakers, and for instance, in my position as a member of the Physician Prescribing Committee for the College of Physicians and Surgeons, where we monitor all physicians' prescribing practices through the electronic data pool in the province of Alberta to see where the problems are and where we need to educate physicians. This paper gives us tremendous evidence to do more work in educating primary care physicians as well as other specialty practice physicians, for instance, psychiatry, in the use of these drugs and the potential hazards. So I think that's the value of the paper, to guide us in educating physicians. Having said all of that, it's very important for everyone to understand that the foundation of the management of insomnia in primary care is behavioral treatment, not drugs.
I agree with Dr. Samuels and with the recommendations, but I want to go back to what Dr. Nissen said. Dr. Nissen is famous for doing clinical trials of 10 and 20,000 subjects, which is what's needed to study mortality effects. But the hypnotic manufacturers, knowing about these risks for over 20 years, have never chosen to do a clinical trial larger than 1,000 patients. They have never wanted to do a trial which would show whether or not their drugs kill people or not. So our best evidence is now 19 studies showing association. With 19
but I mean, I would argue that this is a paper you now write an NIH proposal for and get proper non-industry funding to do these kinds of trials. I mean,
oh, that's so silly. I've written 10 proposals over 30 years. The NIH has never funded such a study, and they're not interested in doing it now. It's not going to happen. We have to decide now.
Yeah, the FDA can mandate it, and they should, as they should. For the study we're now doing with the NSAIDs and COX inhibitors, which is 24,000 patients, and this is a regulatory required study, and I think we need to put a lot of heat on the FDA to do that, and I think it's okay to say that, frankly.
And that's the value of this paper. You couldn't get stronger evidence, again, with other papers to say, look, we got to look at this problem. Because it is, if I can just get, a 2011 paper in Sleep, July, Canadian National Population Health Survey, 130,000 people in Canada, the increase in the prevalence of prescribing of sedative medication was 5.5% from the 1990s to 2000. I mean, we're prescribing more of these drugs, and to the wrong people, because that's an increased prescribing in morbidly obese patients.
Okay.
That's a problem.
What pharmacists have to understand today is a duty to warn. Our best evidence is that these drugs increase mortality and cancer. It's not conclusive evidence, but that's the predominance of evidence. There is a duty to warn, and without warning, there is no defense against litigation, which is going to occur. There's going to be maybe more litigation about sleeping pills than about Vioxx, and you need to be thinking about your duty to warn and your ethical duty to do no harm.
Steve's earlier point is right that there's not a lot of, I don't see a lot of upside to these drugs.
When they're used appropriately, these drugs have a tremendous upside. The question is the appropriate prescribing of the medication. So once again, for people who work in tertiary care centers and see a very, do not work in primary and community care settings, be very careful about these kinds of claims that you make, because just saying something doesn't have an upside, that's just not appropriate.
What's the upside?
You have to look at the nature of the practice. In speaking about this issue with the director of our institute last night, because he was concerned about all of this, and, the fact is that he said in his setting, where he's working in a tertiary care setting as an internist, admitting patients, elderly patients who've fallen from hip fractures, and seeing the amount of sedative medication that they're on and the prevalence with which these drugs are prescribed, that's a concern to him. And so, yes, they're coming from the community. Absolutely, get it. But it's really important to understand this is a problem with educating physicians to prescribe appropriately and monitor and follow the prescribing. That is, in fact, what does not get done.
But I'm looking for what are the appropriate indications. I mean, I can't figure out, where there's any evidence.
When you're dealing with psychiatric patients who have issues related to their depression, which was not...
Oh, come on, I'm a psychiatrist.
Exactly, and depression was not factored into the stratification of the study, which, a lot of people are looking at that as a major weakness in the design of the study.
I still don't see much upside, Sherry.
Yeah, I'm going to jump in right here in the interest of time. This is Sherry. Thanks, everybody, for your comments, but I do need to move on. But I do want to just, before we move on, there is something that I'm hearing that is similar between what you're all are saying, and that is that you need to limit use of sleeping pills. They are overprescribed. Physicians need to be taught about how to appropriately use them.
With Prescriber's Letter, you get evidence-based CME credits that are approved by the AAPA when you read the recommendations. You can even track your CME online. Get your statements online that you can print at any time.
I have enjoyed reading the Prescriber's Letter mailings, and I complete them for CME purposes. I appreciate the ability to enter the post-tests online and like to keep the paper information for my reference. I have accessed the website for further information or for clarifying data. I find the site very user-friendly and up-to-date. I love Prescriber's Letter. It is the best new CME tool I've obtained in the past 5 years. I look forward to its arrival, and unlike many other CME things I've tried, I actually read it cover to cover and take the tests. In fact, I wish it came more often.
Use prescribersletter.com to answer your drug therapy questions. Get unbiased answers that save you time and enhance your patient care. You get answers from the entire archives of Prescriber's letter. Plus, you accumulate point-of-care CME credit each time you use prescribersletter.com to answer your clinical questions. CME as you go tallies up your search activity and gives you full credit. Simply ask a clinical question, get your answer, and accumulate CME credit. CME as you go tracks your activity and eligible credit to claim whenever you want.
CME as you go is absolutely amazing. I just logged onto it tonight during my ER shift. The search is great. It brings up all pertinent information and patient handout materials, and I'm logging CME at the same time. You will always have me as a customer.
You can get answers anytime, anywhere on your iPhone, iPod Touch, iPad, Android, or other mobile device. With our PL iPhone and PL Android apps, you can get recommendations, get answers instantly, get CME on the go.
Thank you so much for the iPhone application. You guys did a great job with the iPhone interface, making the contents so easy to read. I can't thank you all enough.
Your subscription includes access to webinars where the PL experts hold feisty debates about the latest drug controversies. And you get CME from these sessions. You can choose live day or evening sessions, or listen to recorded webinars anytime you wish. Here are a few sample segments.
Hi everyone, this is Sherry Bowringer. I'm an Associate Editor for Prescriber's Letter and Pharmacist's Letter. This set of recommendations is about strategies for managing hyperglycemia in adults with type 2 diabetes. And the American Diabetes Association has a new position statement which offers a more patient-centered approach to management of diabetes. And in terms of drug therapy, metformin is still the first-line choice for most patients, but ADA is offering more therapy choices. And here to help us today with these recommendations, we do have a couple individuals active in the ADA, including Dr. Craig Williams and Dr. Ann Peters. And Dr. Peters actually is a contributing author to this new position statement. So Ann and Craig and other panelists, we're delighted to have more choices of drugs to add to metformin, but we're still trying to help clinicians decide which one to add for patients. And kind of the oral choices, sulfonylurea and Actos, they kind of have some downsides. So we're seeing the DPP-4 inhibitors such as Januvia, very popular choices since they're available orally. However, they don't lower A1C as well as sulfonylureas and Actos. So I just wanted to ask you all and get your opinions on adding them to metformin. We're saying save them for patients close to goal. Do you agree with this?
I think they're fourth-line agents.
Fourth line.
Yeah. I mean, you know, their popularity is amazing given how very little efficacy they have, particularly in people close to goal. Now, you know, I can't believe how these drugs have taken off. Ann, I'm interested in your thoughts, too.
Yes, Ann.
Well, so this is the deal. So everybody wants a simple answer for the second step in treatment, and it'd be really wonderful if I could give it, but I can't.
Mm-hmm.
Just try, Ann.
I can't. So what I say is that you've got to individualize this based on the patient. And
okay,
I personally think that for many patients, for instance, if you have a patient and you've decided that your target for them, and remember this is a patient-centric guideline where we individualize targets. So if I had a guy who was 45 years old, came to see me, his A1C is on metformin still about 6.8, and I want to get him down to below 6.5, a DPP-4 inhibitor makes a lot of sense. But if I have a patient whose A1C is 8 or 9, and I want to get them to target a GLP-1 receptor agonist, the second-line therapy makes a lot of sense. But it's expensive, and it's an injection. If I'm in East LA where patients don't have access to medical care, they don't have a lot of money, sulfonylurea agent would be my next choice. So that's why we made all of the steps patient-centric, that we want to look at the patient, their situation, and then assess what they need next. There's no one right answer, and there's no one best therapy. And that's what we wanted to stress, was how, as a clinician, you look at a patient and the setting in which a patient is treated and make choices. So it makes it frustrating if you want actual prescriptive guidelines. And I at first wanted our committee to come up with that. And in the end, we decided that you couldn't based on the real world of diabetes treatment.
Yeah, I think one point that comes across well in the document, which is a point well taken, is there's just not the body of comparative literature that you kind of hope we might have for some of these agents at this point, where I think we've all recognized metformin as a first-line agent for quite a while, and it'd be great to have 4 or 5 year trials where you add pioglitazone versus adding sulfonylurea and see what happens. But I think Steve's point is well taken, that there is still some unknowns to some of these newer medicines that we just don't have the same volume of clinical years of experience with them to know if there's anything surprising out there still. But yeah, I agree with the general approach certainly that the committee took, and like these much more than the previous kind of glycemic recommendations from the consensus.
Well, they give more choice, which is nice. And what I'm hearing Anne say, and I think maybe we can make this point more clear in our article, is that basically we need to individualize therapy. So in terms of, back to the question about the DPP-4 inhibitors like Januvia, they seem popular, but you know what? They're really not the best choice for everybody. And I think you gave a terrific example. And, you know, bringing up the fact if you have somebody with A1C or 8 or 9, they're probably not the best choice to go to. And I see we do have lots of audience questions coming in. So Jill?
Yeah, we have lots. Okay, here's the first one. Years ago, metformin was contraindicated in renal insufficiency. The questioner understands that this has changed, but who now should we avoid metformin in?
I'm sure that came up for Ann. I have an answer. I'll see if I'm sure that came up in discussion at the committee, Ann.
Yes, a lot, because the European guidelines differ from the U.S. guidelines.
This is Steve Nissen. It's been my impression, reading the literature, that the risk of lactic acidosis has been overstated for metformin, that it's really a very rare side effect, and that probably, particularly in the U.S., we're too conservative in our thinking about when we should not use metformin. That is to say that lots of people with mild renal insufficiency can be treated, particularly if you're willing to use a little bit lower dose.
Yeah, that's a very accurate summary of a lot of literature.
Okay. Yeah. What kind of serum creatinine cutoff should we be looking at?
Well, so we don't look, so in Europe, they don't look at serum creatinines, and they look at EGFR.
Right.
And the European guidelines, which I, in my practice, have largely adopted because I think it makes a lot of sense, is if the EGFR is 60 or more, then you don't have to dose reduce. So you use 1 gram twice a day. If it's between 30 and 60, you cut back to half that, so it's 1 gram a day max dose, and if it's less than 30, you don't use it. And that's what they've used quite successfully there, and that's what the European standard is. So it's different from the FDA, which uses a serum creatinine level, but I think the European guidelines make more sense in that instance.
Okay. Jill, one more audience question about sulfonylureas?
Yep, I've got a great classic one here. It's the old adage of sulfonylureas burning out the pancreas. Is that true? Is there any basis for being concerned about that anymore, or what's the deal?
Well, this is Anne. So from my perspective, diabetes burns out the pancreas, and all the treatments that we have except for the TZDs have been shown to be associated with progressive disease. So if you use metformin, if you use a sulfonylurea agent, if you use insulin, patients get worse over time. And so sulfonylurea agents may or may not burn it out faster. What worries me about sulfonylurea agents is that they increase insulin secretion, cause hypoglycemia and weight gain. But you know, I think you really need to do things that help patients with lifestyle, weight reduction, et cetera, to help their insulin resistance go down. And I think that the TZDs, and now we have Actos left, at a low dose also help preserve beta cell function.
Yeah, there's some data that some of those other agents, glutazones in particular, may have a little better longevity in terms of how long they kind of maintain glycemic control, but it's not clear that's because sulfonylureas are quote-unquote burning out. That wouldn't be a hesitation I'd have in using a sulfonylurea in an otherwise appropriate patient.
I do think the durability of pioglitazone is a valuable thing to be aware of, and probably is worth some commentary.
Thanks so much, Drs. Nissen, Peters, and Williams, for helping us refine those recommendations about the management of hyperglycemia.
If you are affiliated with a student
Hello
program,
everyone, this
you
is
will
Sherry
want to get
Boehringer. I'm an associate editor for Prescriber's Letter and Pharmacist's Letter. For this set of recommendations, we'll be discussing the prevention and treatment of Lyme disease. The reason we're talking about this now is because we've had a mild winter and an early spring, which means that ticks are going to be flourishing. And depending on where you live, you might get more questions about ticks as well as Lyme disease and how to prevent or treat Lyme disease. So this is a very controversial topic, and there are a couple schools of thought regarding the treatment of Lyme disease, and here to help us with these recommendations we have
Journal Club.
two Lyme experts. We have Dr. John Halperin,
We do the
who
digging.
is a contributing author to the Infectious Diseases Society of America guidelines on Lyme, as well as Dr. Betty Maloney, who offers a different view on the management of Lyme. So John, I'm going to start with you. And one of the areas where there is controversy is antibiotic prophylaxis. And we've actually kind of highlighted some information on antibiotic prophylaxis. And I know IDSA recommends giving a single dose of doxycycline if somebody's been bitten by a tick and it's been attached for 36 hours or more. And I know this is controversial. So John, can you just kind of give us a little insight on the rationale for this recommendation?
If you look at the studies on this, the biggest study looked at single-dose prophylaxis. There was actually a meta-analysis done by some of the same authors subsequently, and that drew on 3 additional studies. And actually, the other studies all used 10 days of treatment. So I don't know that the exact dosing and duration is clearly established by any means. The basic issue is that if you look at the placebo-treated patients in all the studies, the frequency of infection without treatment is on the order of 2%. If you look at the frequency of infection in those who got an antibiotic, it's 1/10 that. So certainly the risk ratio favors treatment, but it's a difference of very small numbers. The other side of the coin is that among the patients who were treated, the frequency of some side effects was above 2%, and the frequency of patients who got an infection without symptoms to mark it was arguably 0 and maybe a few. So if you look at the whole thing in balance, the 2 potential strategies are either nothing and watch and see, and if you're very nervous, get a follow-up titer. Number 2, a single dose of prophylaxis. And number 3, looking at older studies, you could probably justify a longer course, but realize you're going to get more side effects as the price of doing that.
Okay, so I appreciate you basically saying there's 3 choices. Kind of watchful waiting, I guess you could say. The single dose, and then the longer duration. And Betty, I think you're more of a fan of the longer duration of doxycycline for 10 to 20 days. So I'd like to hear your thoughts on that.
First off, the single-dose doxycycline trial really didn't prove that it prevented Lyme disease. It prevented the development of an erythema migrans at the bite site. So they used a surrogate. And they only watched patients for 6 weeks. But as you note later in the article, that late Lyme can come on months or years later. So they really didn't have a sufficient observation period to claim prevention of Lyme disease. And even using their endpoints, what they found is there were 3 patients in that trial who had symptoms of early Lyme disease and seroconverted, but they were not counted as disease positive. And so when you really look at what that came out of the trials, they showed that single-dose doxycycline can decrease the risk of a rash at the bite site. And actually the risk in the placebo group was, I calculated at 4.2 when I add in the 2 people who had early Lyme absent the EM. So the reason for the longer duration is if you're going to prophylax someone, if that's the choice you've made with your patient, then let's really prevent Lyme disease, and that comes from mouse studies where they found that single-dose approach in the mice was only 43% effective, and this they know with certainty because they can sacrifice the animals. But when they gave a long-acting form that hung around for 19 days at a low level, they found that 100% of the mice were protected, and this also applied when it was a dual infection with Lyme and anaplasma, which is something that has to be considered in many parts of the country.
given that 3 of the 4 studies actually used 10 days of treatment, I don't want to take a strong position that one dose is sufficient. I think you can make a strong case either way. I think that you're right that not every single person has developed erythema migrans. I think that in the studies, they did do a long enough follow-up to see if there was seroconversion. And if you follow someone out for 6 weeks, it's extraordinarily unusual to get an infection without seroconversion at that point.
Okay. Well, I think that both of what you guys are saying is helping us, because it sounds like we don't know for sure, but I feel a little bit more comfortable saying single dose or possibly these longer doses. We do have some audience questions that I wanted to get to. Jill?
Yep, we do. We've got an attendee asking, do all patients get the bullseye rash? What other symptoms should we look for? Kind of give us the constellation there.
Sure. Not all patients get the bullseye rash, and in fact, of the rashes, the most common rash is actually homogeneously colored oval, not with the central coloring. Bullseyes occur in about 20% of less. And more importantly is looking at the CDC data, it appears that 30% of the cases reported to the CDC lacked any rash. And so rash is not a universal. So other signs can be fever, chills, arthralgias, myalgias, headache, stiff neck. One that's always caught my eye in the early studies is the complaint of pharyngitis, and with that, this finding of cervical lymphadenopathy. So it's a broad spectrum of symptoms.
The only thing I would really potentially differ on is in terms of the frequency of the rash. Certainly it can take any of a number of sizes, shapes, and description, and does not have to be a beautiful bullseye. The studies come in 2 flavors. There's studies in kids and studies in adults. When it comes to studies in adults, the usual number that's quoted is about 50%, and that's if you get a rash, presumably people can get rashes where they can't see. The 50% of us who have a Y chromosome are oblivious to anything that happens to us, so we never report anything. If you look at little kids, they tend to be watched by their parents fairly closely. And in them, the incidence is about 90% of kids have a rash. So it's certainly true that not everybody has one. It's certainly a high percentage, with the exact percentage unclear. On the systemic symptoms, I think the pharyngitis sort of fell by the wayside, but the systemic fever, myalgias, arthralgias, all that stuff certainly is typical.
Thanks so much, Drs. Halperin and Maloney, for helping us refine those recommendations on the management of Lyme disease. Hi everyone, this is Sherry Bowringer. I'm an Associate Editor for Prescriber's Letter and Pharmacist's Letter. Our next set of recommendations is about whether routine monitoring of liver enzymes is necessary in statin patients. And there's actually been a significant change in how often liver enzymes are supposed to be monitored in statin patients. You're probably used to checking these enzymes when starting a statin, after dose increases, and then once or twice a year. But now labeling is no longer recommending this monitoring. And they only suggest monitoring before starting a statin and then if patients have symptoms. So to help us with our recommendations, we are so lucky to have with us today Dr. Jim McKinney, who wrote a statement about 6 years ago on behalf of the National Lipid Association, letting providers know that liver failure with statins is rare, if it happens at all, and also routine monitoring is probably unnecessary. So Jim, I'm wondering if you can kind of give us a little background on why statins seem to have gotten a bad rap to begin with for causing liver injury, and also, why did it take the FDA so long to change labeling if we knew routine monitoring wasn't helpful?
I don't know if we understood routine monitoring at the time that these statins were released was not going to be helpful. We knew that the drugs, frankly, as a class, all increase transaminase levels, at least modestly, from time to time in transient fashion. The first statin, lovastatin, Mevacor, in 1987, we had very little understanding. So it was logical at that time to monitor these things and the off chance that they may predict future pathology. But now we have 25 years of experience, and we know a lot more about what these tests mean, and certainly what statins, how statins may participate, if at all, in the significant liver injury, that is dysfunction of the liver. So it's time for a change. That's what we recognized in 2007. forensics and tried to articulate that. We had a panel of hepatologists that helped us. We used evidence-based. I'm very proud of what our colleagues did. And finally, actually, the FDA cited our work as one of the citations they used when they came out with the recommendations.
Okay. Yes, I noticed that actually. Go ahead, Steve.
This is Steve Nissen, and I completely agree with Jim McKinney. You know, interesting enough, I don't think I've ordered liver enzymes on a patient on statins in at least a decade. And most of the people I know who are very experienced lipidologists feel the same way. In fact, what I actually teach people is the one thing you never want to do in a patient on statins is check liver enzymes, because some fool is likely to look at them and actually stop the drug.
Yes.
And then the patient has a myocardial infarction or a stroke. So
yes.
This was always an airball, and it's now to get back on track. Now, you know, occasionally, if someone has, you know, liver disease and we want to give them a statin, we maybe want to be a little bit more cautious, but it's not for the majority.
Yeah, so, you know, it's still a reason that it was not an uncommon reason. People referred to a lipid clinic was for elevated transaminases, and then people wondering what they can give as far as treatment because they thought you couldn't use a statin. But as Jim says, we've learned a lot, and you know, I think I point out here the package insert for a couple statins has been pretty lax on monitoring for quite a while, basically saying get a baseline then when clinically indicated. So for SIMBA, for example, since our protection study, that's really been the labeling. So a lot of us have not been monitoring very much for quite a while now.
You know, this is Andrea Darby Stewart, and I'm very happy that the FDA has come out and finally said that we don't necessarily have to, well, we don't have to monitor, because I think this is going to really help cut down on costs. I can tell you that people aren't just ordering transaminases. They hit the simple button, which is CMP, when they're doing their quote-unquote ordering, and I think that we're going to see a significant decrease in a bunch of unnecessary labs because of this, as long as we can get our patients to buy in and our colleagues to buy in as well.
The questions are coming in from the audience about, well, what do you do if you do happen to run a liver function test and the enzymes do come back high? How high is too high? Would you ever consider not starting a statin or discontinuing it or lowering the dose?
Good question. Jim, would you like to take that one?
So I'll start off, but certainly the recommendations are not to look, because if you look, you may find, and then you have to figure out what to do. And we know that the significant liver injury that we'd like to detect happens perhaps in 1 case out of 1 million people, million statin users. Imagine how many people you'd have to monitor to find it, and you probably won't find it even then. So it's not logical. But if you should have a patient who has an LFT or transaminase of some type greater than 3 times the upper limit of normal, then repeat it. You don't have to do it the next day. You can repeat it in a week or so. And if it's still elevated, then perhaps you want to look at whether there are symptoms. I think the FDA would recommend, we certainly do in research, that a total bilirubin be ordered, because you really are looking for functional differences. The liver now has a dysfunction because of the injury, not just a transaminase elevation, but something that indicates functional change. And a total bilirubin level or a INR or something like that may give you a clue. And of course, then you rule out other causes, viral hepatitis, alcohol, and so forth. But that's a full workup, and I don't know that you would very rarely go to that extent. Because, frankly, about 70% of all elevations are transient, and you're not going to see them again. If you just follow that asymptomatic patient out, I suspect those elevated liver function tests will come back normal.
I'll reinforce that the labeling always said persistent elevations, and so a single elevation, we catch single elevations, and totally healthy people were screening for clinical trials, and so I think it's certainly worth noting that it needs to be persistent elevation. So if you get an elevated one, bring it back. We wait longer than a week just because who knows what may be going on with that one spurious finding. So we do more like 3 to 4 weeks out. And then if you just do that, you'll get rid of more than 9 out of 10 patients you're worried about in the first place. And I think people might have different approaches to that 10th out of 10 patient, but it should be persistent. There should be some time, I think, between those 2 LFT checks.
Interestingly enough, the patients that do turn up with abnormal liver function studies, almost all the time you find another cause if you look hard enough, so that this really gets labeled as being statin-induced a lot of the time when it's really not.
Okay, so if it's high, even in the beginning, it sounds like you want to go ahead and recheck that. Is that correct, panelists?
Certainly go ahead, but I don't think it should slow you down from using the drug.
Especially if a good indication. I mean, it's reasonable to look at why are you starting a statin in this
That's
person.
correct. Non-alcoholic steatohepatitis as well as NAFL, both were actually indications to use statins as opposed just to the opposite.
Okay.
Just because you have a fatty liver or and therefore an increase in enzymes doesn't mean that you can't use your statin.
Okay, and I'm glad that you mentioned that because we actually have a recommendation a little bit further down in the article that says feel comfortable using a statin in patients with elevated liver enzymes due to chronic stable liver disease, especially non-alcoholic fatty liver disease. So I'm guessing that you guys all agree with that recommendation. Is that correct?
Yes.
Yes.
Okay, very good. And Karen, any other audience questions that we can get to?
There is a question about whether or not you should stop the statin if they have a high bilirubin. Symptoms plus a high bilirubin, excuse me.
If they have a symptom of high bilirubin, by all means, I would stop the statin. There's an enormous capacity to eliminate bilirubin by the liver, and if you see an elevation, that means you have pretty sizable and substantial injury. And so you would certainly want to withdraw the statin in that circumstance and go through your process of trying to rule out other causes.
Just keep in mind it may be Gilbert's, however.
And it may be. And it may be alcohol probably, and it's probably viral hepatitis, all those other things. But you have to respect, I think, now, this is open to debate, but my personal opinion is you have to respect an increase. And now I'm talking about 2 times the upper limit of normal bilirubin. In a patient with symptoms on a statin, I would respect those findings.
I think Sherry asked about cut points, and I think what's in the labeling, 3 times upper limit of normal, I think is a reasonable thing to use for what might be considered elevated. And that's going to be different in different people's labs, but so whatever your upper limit of normal is at your lab.
Thanks so much, Dr. McKinney and other panelists for helping us refine those recommendations about when to monitor liver enzymes in patients taking statins.
If you are affiliated with a student program, you will want to get PL Journal Club. We do the digging, so you can focus on the discussing. PL Journal Club gives you materials to have regular, highly educational journal club meetings. You get sample questions to guide the discussion, plus you get the answers. We give you all the online tools to make Journal Club easy. Select from over 125 PL Journal Club packets. PL Journal Club makes Journal Club easy for you and the participants. Participants get everything they need online, including case-based examples, background reading, and reference citations. Plus, they can interact with other Journal Club members across North America.
We use PL Journal Club all year with our faculty and students, and they all enjoy the product. The faculty love the ease of use, and the fact that it helps us teach the basics about how to critically evaluate the literature. It's a nice segue into our more advanced teaching on this topic.
To learn more about getting Prescriber's Letter at the special AAPA show rate, go to www.prescribersletter.com/AAPA meeting, or use your mobile device to scan the QR code on the screen.